20 question or 15 question in 9 minutes. Most of the pathology topics is not able to do that. So what we have, sometimes they can start, for example, as we mentioned just now, diverticulitis, and suddenly he ask you about something not related at all, like endometriosis, not related, but because he need to ask you many topic in pathology, and sometimes topic related like he ask you about reflux esophagitis, Barrett esophagus, then cancer esophagus, so can be related. Some not related like this. So you started by diverticulitis, and suddenly ask about endometriosis. Endometriosis is the presence of the endometrium gland or tissue in the site outside the uterus. Can be in the umbilicus, can be in the abdomen, can be related to ovary, can cause pelvic inflammation, can cause infertility, can cause pain. It can occur in any area around genitalia. So can be an ovary, around ligament, fallopian tube, pelvic, peritoneum, can be an intestinal wall, umbilicus, laparotomy scar, very rare in lung, pleura, and synovium. So what is the problem of this? The problem of this is the patient, of course, when she is young, no problem. Once she's become in puberty and they have menstruation and hormone, so they can cause bleeding or pain at time of menstruation. Of course, it's very rare, but can happen if the patient have ectopic endometrium cells in the umbilicus, so they can bleed at time of menstruation. Is very rare, but can happen, and is one of differential diagnosis of the vague abdominal pain. So put in your mind this type of endometriosis. So they usually, it is affected at time of menstruation. Sometimes it's difficult to be diagnosed or explained. Sometimes discovered accidentally. Sometimes they have a bleeding. So whatever you have, it is important to evaluate it. Of course, nowadays by laparoscope and biopsy or tissue histopathology, so you can be diagnosed. Of course, sometimes it can be cause adhesion, and this adhesion can cause intestinal obstruction. No much detail in endometriosis. We need it from you in the exam. After that, we have one of the common swelling or cancers in Malaysia, not in UK or England, is the cancer colon. So you can find script like this. If you have a 65 years old man, attend the outpatient clinic, complain from irritable bowel habit. So the examiner asks you some question. Okay, so the first, of course, in the patient with colonic symptom, what other colonic symptom is usually irritable bowel habit, painless bleeding of the rectum, tenesmus, which is incomplete evacuation, fecal incontinence, loss weight, loss of appetite. Sometimes you ask you how to differentiate between cancer colon and diverticulitis. We just speak about diverticulitis. Anyone can have the answer how to differentiate from the history, even before colonoscope, of course, between diverticulitis and cancer colon. Anyone have an idea? Yeah. All right. Yes.
Diverticulitis, usually patient has fever.
Yeah. So the important differentiation is the patient with diverticulitis usually have fever. The patient with cancer colon no have fever. Also loss of weight, loss of appetite. Both cancer and diverticulitis can have irritable bowel habit, painless bleeding of the rectum. Usually diverticulitis have pain in left iliac fossa and have fever and of course leukocytosis. So it is important to know the difference. Of course, if you do colonoscope, you can see that diverticulosis is different than cancer colon. Of course, if we speak about colonic tumor, we start by benign lesion like adenoma, which is villus adenoma tumovillus, familial adenomatous polyposis, which is autosomal dominant disease, precancerous condition, one of adenoma carcinoma sequencing. We have juvenile polyp. Nowadays, we have one of these polyp, we call it serrated polyp. Serrated means that the end of it is irregular, like serrated, like so. And this is serrated is very dangerous and highly precancerous or highly turn malignant. So it is important to just They ask about this. Of course, this is polyp, can be hypertrophic polyp, can be pseudo polyp. Pseudo polyp is usually in the articulitis. It is not true polyp, but most of this polyp is true polyp. So villus, tubular, or tubovillus. The precancerous one is familial adenomatous polyposis and also serrated polyp. So this polyp like this, and this polyp if single, so it is better to remove it and send it for histopathology, and this is called snaring. Multiple polyp, which is familial adenomatous polyposis, which is a precancerous condition. In general, polyp can be adenomatous, like tubovillus and tubular. Can be inflammatory, like pseudo polyp in the articulitis. Can be hamartoma, which is tumor-like, not malignant and at all, not precancerous at all, which is Betsch-Jeher syndrome, which is polyp in small and large intestine. Neoplastic, which is cancer. So what is important for us? Pseudopolyp in articulitis, hamartomatous polyp, Betsch-Jeher, not precancerous, neoplastic polyp is a cancer, and usually it is in the top of familial adenomatous polyposis, which is autosomal dominant disease. This is pseudopolyp for articulitis. So cancer colon, we are now in cancer colon. Under microscope, all cancer colon adenocarcinoma. But macroscopic or gross anatomy can be polyp, can be ulcer, can be stenotic. So this is the varieties of the cancer colon. Diagnosis usually history, fecal occult blood, confirmed by colonoscope, and follow up by tumor marker carcinogenic embryonic antigen after remove as a baseline to detect any recurrence. This is a polyp, common site of the cancer, usually rectosigmoid, left side. Sometimes in cecum, very rare and usually difficult to diagnose, and usually patient presented with anemia, which is iron deficiency anemia, macrocytic hypochromic anemia, or fecal occult blood in urine, in stool. Or can be ulcer, so ulcerated lesion. We have ulcer, we have polyp, we have stenosis. Okay. Of course, we have many systems for staging. The important to know it is Dukes and TNM. Dukes, we have A, B, C. So A, just within the wall, B, take all layer, C, involved with the lymph node, and D, metastatic to the liver. So what is the important to know this staging? Because although this staging done post-operative, but it gives idea about 5-year survival. So in stage 1 or A, it is 5-year survival is 90%. If the patient have distal metastasis, is 15%. Usually the patient have distal metastasis or metastasis in the liver, and this is due to portal vein. So this is due to portal circulation. So for drainage of the, superior rectal vein to inferior mesenteric vein to portal vein. This is Dukes or modified Dukes. Of course, the tumor marker used for follow-up and sometimes in diagnosis is carcinogenic embryonic antigen. Any patient have a cancer colon, you must diagnose metastasis by CT, TAP, or thorax, abdomen, and pelvis. And TNM staging or Dukes staging done post-operative, not pre-operative. TNM staging, the important to know that it is T2 is invading muscularis propria, T3 penetrated muscularis propria, T4 invading nearby organ. Don't need to have the subdivision A, B, C, or this, no need. N0 no lymph node, N1 3 lymph node, N2 more than 3, so it is 4 and more. N3 higher lymph node, M0 no distal metastasis, M1 distal metastasis, and no egg by CT, thorax, abdomen, and pelvis. If MX means that we don't do that, which is not good. So this is again, if it is invading nearby structures, so T4, if it is superficial, if it is invading muscularis propria, T2, if it is all layer of the colon, T3. Cancer colon is one of the important topics you need to know in the exam because it is one of the commonest cancer in United Kingdom. Okay. Any question till now?
Yeah,
Of
actually,
course.
Prof, I have a question just now regarding the history taking. Like, how do you assess the history taking for outer bowel habits? What questions do you ask the patient in that regard? Thank you.
Yeah, if it is history taken station, not pathology station, so you need to ask this question I just show you now. You need to ask first, usually in the script as written here is alter bowel habit. So you need to ask about alter bowel habit. You need to ask about Baylis bleeding rectum, fresh or mixed with stool. If it's fresh, so it is from anus. It's mixed with stool, so it is upper. You ask about incomplete evacuation, which is tenesmus. You ask about fecal incontinence. You ask about loss of weight, loss of appetite, and also ask about fever to exclude diverticulitis. Okay, so this is the important topics to be asked. I see some people from Middle East usually ask about bone ache and all this. They're looking for the extraintestinal manifestation of the ulcerative colitis, but ulcerative colitis need to have long history, and of course they have a risk of malignancy. If you need to ask, no problem, but usually you ask about this topic in other part of history, which is other system, because again, history is a history, so must ask about social history, family history, other system, and any admission, any medication. If the patient have endoscope, usually in exams, the patient say, I have endoscopes. You ask, what is the doctor tell you about endoscope? Or the examiner shows a picture of endoscope, a colonoscope, of course. So it is in the simple way, like this is not difficult. Of course, they take a history in 6 minutes, and the discussion or talking is in 3 minutes. Okay. Second topic, which is important as British exam, is inflammatory bowel disease. Inflammatory bowel disease is not common in most of the country in Middle East and Far East, but in UK and America is common. The common is Crohn's and ulcerative colitis. Of course, Crohn's occur in any part from mouth to anus. Terminal ileum is the usual, so this is have the name regional enteritis or ileitis. Of course, in England, they come in differential diagnosis of pain in right iliac fossa, like differential diagnosis of acute appendicitis. Macroscopic picture, so it is edematous mucosa fissure, and this fissure is penetrated or layered because the Crohn's disease is transmural, so it is affecting mucosa, submucosa, muscularis propria, till serosa, and this is explain why fistula is common in this disease. Of course, you found intestinal wall is thick and serosa is inflamed. This is macroscopic, like gross anatomy, like this. But microscopic, it is granuloma. In all layer affected, non-caseated granuloma to differentiate between it and tuberculosis, multinucleated giant cell, epithelioid cell, perivascular infiltration by lymphocyte. Ulcerative colitis, no granuloma at all. It is just a mucosa, submucosa affection, no granuloma at all. So what is granuloma? Is aggregation of the activated macrophage or epithelioid cells. And different between Crohn's and ulcerative colitis that the superficial layer, mucosa, submucosa, is only affected in ulcerative colitis, and it is no granuloma. Crohn's disease transmural affects the whole area, and it is non-caseated granuloma. Of course, ulcerative colitis start mainly from the rectum and the proximal till have pancolitis, also little affection in the ileum. Crohn's disease can affect any part from the GIT, started from mouth to anus. And of course, Crohn's have a fistula. Crohn's can cause perianal fistula, can cause a fistula between organ, can have adhesion, can have a stricture. Ulcerative colitis can cause megacolon and also have a risk of malignancy. Yeah, it is the same. Okay, if you see this picture, is to differentiate between TB, tuberculosis, usually caseated granuloma like this, caseated being clear like cheese, but this is non-caseated granuloma characteristic of the Crohn's disease. Complication of Crohn's can be fibrosis, stricture, intestinal obstruction, fistula formation, perforation, abscess, peritonitis. Of course, because of the repeated shedding of mucosa, the patient can have malabsorption or malnutrition, perianal abscess, ulceration, or fistula. Associated condition, what is called the extra-intestinal manifestation, and is common in both Crohn's and ulcerative colitis, which is ankylosing spondylitis, arthritis, and sometimes eye manifestation. Of course, the indication of surgery is limited. We just, if you have adhesion, to remove the adhesion, nowadays can done by laparoscope. If you have fistula, of course, you manage the fistula. If you have stricture, just sclerotomy or just bypass. But we don't have massive surgery because this patient usually have the repeated pathology. This is the mucosa healthy, this non-healthy, this area of stricture and perforation in the Crohn's disease. This is ankylosing spondylitis. It is one of extra-intestinal manifestation. It's called bamboo shape appearing X-ray, HLA, I think 27, human leukocytic antigen. By the way, for whom enters the exam in examination of the spinal cord in exam, it is important to do Schubert test. The Schubert test is you measure the back and ask the patient to lean forward, and you can find the area is increased. This is test done to exclude ankylosing spondylitis, because ankylosing spondylitis is common in European country. I know that in the Middle East, we don't do this measurement in examining of spine, but in England, it is mandatory. Okay? I think, Dr. Ho, you elevate your hand. Any question?
Yes, Dr. Shireen. Just
Yes.
now you show us the histology slide. I'm just wondering, will it be a question where the examiner show us histology slide and ask us what is the disease that manifests this
No,
slide?
no. He just
To
asked
recognize
you. He don't show you. He can show X-ray, but not show histology at all in exam.
Okay, sure. Thank you, doctor.
All right. Okay. The exam is easy because this is surgical pathology. You don't supposed to be expert in histopathology. Okay. All right. So again, it is important who will enter the exam, whatever coming few weeks or coming few days, or in September in Malaysia. It is important in examination of spine, which is a common station. You need to do measurement, so it is very, very, very important. And this is called Schubert test. And it is mainly for ankylosing spondylitis, by the way. Again, it is common in England because they have Crohn's disease and arthritis is common, so they have extra-intestinal manifestation. Okay. Apart from this, we have something in bone. Okay, any questions so far? Okay. All right, I just a quick revision of some term. Of course, in pathology, usually they ask you about definition, and also this rapid question, like what is osteoporosis? Is a reduction of bone density. What is density? Is the volume of bone, the volume of anatomical bone is reduced. Usually it is something in stored matrix is reducing the amount, but the picture or histology of the cells is normal. Is the only density is affected. So you can find like the picture, it is faint picture. So it is like osteoporosis, and this is osteoporosis liable to fracture due to mild trauma, which we call it pathological fracture. Osteoporosis, of course, it's a generalized disease, but sometimes it can be localized. Suppose you have plaster in your hand or leg, and you don't move your leg, so can happen. I think Dr. Ahmed, he elevate your hand. What you need to ask? Dr. A.M. Ahmed Mustafa.
I was raised hand to ask a question about the history, but no problem at the end of the station to
No, you
not
can
make
ask,
interruption.
no problem. What is your question?
Okay, I'll ask about the pre-operative confusion station in the history.
Pre-operative confusion. Yes.
Yeah, what shall
We
I
make
do
it.
in this?
We make it, I about to finish, so I will start by pre-operative confusion, and we ask you to present it. You have it in exam before or just prepare for exam?
No, prepare for the exam. My exam in 16.
16, okay. All right. Okay, I will, after I finish this point, I will go to this pre-operative confusion. Okay, so in the osteoporosis, so can be localized, can be generalized, prolonged recumbency in big. You know that movement can increase bone calcium precipitations, embolizations can affect osteoclast, and it is important to have enough calcium to have good mineralization of bone. The second term is osteomalacia, which is like rickets in baby. It is an adequate mineralization. It is inadequate intake, like you have starvation or something, or defect in absorption if you have small bowel surgery or small short bowel syndrome. Defect in vitamin D utilization, which is common in the unexposed to the sun. Common in the people also, they have renal failure because, you know, in the renal failure, vitamin D, which is 125 dihydroxycalciferol, is activated in the liver and the kidney. If you have renal failure, it is not working. Of course, in this type of question, he just ask you definition and causes, not ask in detail, not ask in histopathology. He just ask you in simple way. Of course, the key for this is pathological fracture. Pathological fracture is fracture due to mass trauma, can be osteoporosis, can be secondaries, which is osteolytic secondaries. Most of secondaries osteolytic, except prostate. Primary bone tumor is rare. Bone cyst, fibrous dysplasia, osteogenic imperfecta, which is autoimmune disease. Osteomyelitis is inflammation of bone. Can be due to staph, strep, influenza, salmonella typhi. Salmonella typhi usually in the sickle cell anemia patient. It is inflammation. This is inflammation can cause pus, and this is pus come out from the periosteum, and this is called sinus because it is blind end. It is important to know we have two names. We have sequestrum, which is dead bone, act as a foreign body. We have sinus, which is opening. We have invicrum, which is new bone formation. So, of course, osteoclasts try to destroy sequestrum, but it is better to remove any dead bone, any detached segment of the bone, just to have good healing. If no drainage, can be toxemia or pain. Second thing related to bone is septic arthritis. Septic arthritis, usually in UK, diagnosed by ultrasound, and the taking biopsy in UK is done guided by ultrasound. So suppose the patient had hip pain, knee pain, whatever, usually is done, especially hip, especially in children, done guided by ultrasound, not done by your experience and your expert hand and all this. So all this nowadays, for all joint, even the hand joint, everything is guided by ultrasound. Okay. I just have one slide about sterilization and disinfections, which we found this problem in some Arab country. Sterilization is put something in the autoclave, for example. It is not washing your hand. Washing your hand is called scrub up. Preparing the patient is not sterilization. Okay? So it is just important to know that the sterilization of all instrument is done by autoclave. Suture is by ethylene oxide, which is most of the surgeons don't know that suture is sterile by ethylene oxide. It is in factory. Tydex glutaraldehyde used for sterilization of laparoscope. Gamma radiation used for sterilization of plastic and gloves. Skin preparation, not sterilization, by bovidine iodine. If the patient is sensitive to iodine, we use chlorhexidine. In some area, you can use alcohol 70%, no 100%. Okay. Just a quick for that. Okay. Last topics I have is testicular tumor. Testicular tumor, it is important to know the tumor marker. In testicular tumor is pillis, hard swelling, usually discovered accidentally. The patient may be blamed trauma or something, but not related to trauma. On examination, they hard, irregular, non-tender testicular mass or loss of testicular sensation. Usually, the lymph node enlarged is para-aortic lymph node, so it's not palpable. Of course, teratomas or Yuxak tumor occur in young age, 20, 35. Sometimes in cryptorchidism is risk. In undescended testes, although you put it down, but the risk to become a cancer is also high. And it is not unaffected by ercopexy. So if you put the testes down, it's not decrease the risk because it is hypoplastic, but we just to be visible to us if any cancer or malignancy can detect it. Of course, exposure to some hormones can be affected. We have seminoma, non-seminoma. Seminoma not have a tumor marker, but non-seminomas, we have two tumor have marker. Choriocarcinoma have beta human colonic gonadotrophin, which is 1% not common. Yuxak tumor or teratomas is have alpha-fetoprotein. Other is rare tumor. Of course, metastasis is rare, and testicular tumor usually spread by para-aortic lymph node. Seminoma, you remember, started by S. So usually in seminoma, the para-aortic lymph node is sensitive to radiation. So if the patient have para-aortic lymph node, you can give radiation to the abdomen. But non-seminomatous, especially Yuxak teratoma, lymph node is not affected by radiation, so you need to be removal surgically. So the difference between seminoma and non-seminoma, in seminoma, through inguinal incision, you remove the testis and the spermatic cord and give radiation to para-aortic lymph node. But in teratomas, Yuxak tumor, you remove the testis and open the abdomen and take out if the patient have para-aortic lymph node. If not have, no problem. Of course, you know they have or not have by CT. So again, we have the marker alpha-fetoprotein, beta human colonic gonadotrophin, diagnosis by scrotal ultrasound, chest X-ray, CT, abdomen and chest is mandatory. Of course, put in your mind, in the England, they have sperm banking before you start the surgery, before everything, just in case if the patient have problem later, so you have some sperm in sperm banking. Of course, not all the country have this sperm banking. Stages is not important. So again, management in seminoma is radical orchidectomy and radiotherapy. Retroperitoneal lymph node, you can give chemo or radio, but not surgery at all. In non-seminomatous, you must have retroperitoneal lymph node dissection. Okay, it is very important and very easy to be asked. Okay. I stop here. Is anyone, I think another one have elevated his hand or not?
Yes,
Dr. Hazmin, what you need to ask?
I have a question for
Yes.
testicular tumor. Usually the op is in groin incision. Why don't we do a scrotal incision?
Yeah, it is important. You must be inguinal incision and the clamping by non-crushing the spermatic cord, because if you make through scrotal swelling, you can spread the malignant cell to scrotum and spread to superficial inguinal lymph node.
Okay.
So in the testicular tumor, we don't have fine needle what's called fine needle aspiration. Don't have through cut biopsy. Only biopsy taken. You make inguinal incision. You bring the testis. If you are still worried, you can take sample for forensic section, and after that you can remove it if it is a cancer. This is why when you deliver it, you put non-crush clamping, non-crushing clamping. So because suppose it is become normal, so you remove it. So don't remove the testis. So this is, we don't remove through the scrotum at all. Okay. All right. This is as regards the important topic related to pathology for the exam. Okay. I think is the doctor who asked about history, pre-operative confusion. So we can just start it. Okay, so any question about pathology, by the way, before we start?
Doctor, about the hemorrhoids, this station is important or not?
No, we don't have hemorrhoids. We don't have, but hemorrhoid is not in pathology topic. It's not, I think it's not coming before.
Okay.
Okay. Maybe one question or something, but it's not a station about hemorrhoids. It's not much important.
Okay. Thank you.
Okay. Just looking for delirium, perioperative assessment, headache. Okay. Okay, I am back now, so I just share the heading of perioperative confusion. So doctor who asked about perioperative confusion. Dr. Ahmed Mustafa, what you expected to tell us in this station? So what is your plan if this station come to you?
I know before that I should ask about mental state examination.
Okay, this is the first mistake,
About
doctor. This is the first mistake. Okay, because if you see the script, okay, so you can find here. You see the screen, or shall I share?
Yeah, I see it.
So letter like this, for example, 75 years old, admit to hospital for redo something or total hip replacement, and she's had operation done 15 years ago. You are core training like houseman, doctor asked by senior staff to consent the patient. Okay. Is any mention here in the script that can you please do many mental status?
No.
Okay, so you are volunteer to add something. Say again. I hear you. What you say?
I don't.
Yeah, no, I hear you.
1 second, please.
Okay, take your time.
So do you hear me?
Yes, I hear you.
Okay.
So you need to mention many mental states. Okay. So suppose you mention many mental states. Okay. After that, what you need to tell us? What you need to ask the patient? You finish many mental states. After that, what you will do?
I'll ask about social history and family history, medical and surgical history.
Social, family, medical and what?
Surgical history.
Surgical history. Okay. All right. So in your practice, if you find the patient is confused, what do you think the patient has? Okay. I tell you, we can start as a station and you start to take me history. So we start by me. So I am 75 years old, make it woman, and I have redo elective total hip replacement. This is done 15 years ago. And you are the patient supposed to be confused, and you are Dr. Ahmed, and you are SHO orthopedic, so you can start the station. You can start now. Okay, start. We have a time, so we can calculate the time, and you can start. Suppose you are in exam. Okay, you can start.
Hello, I'm Dr. Omar, one of the surgical doctor. May I confirm your name and age, please?
Yeah, I am Anne Mary. I am 75 years old.
Okay, nice to meet you. Can I know, please, what Can you please, do you know what's your age?
Yeah, I'm 75.
Okay, what's your date of birth?
Yes, we can calculate it. So it is about 1950. 7 January 1950, I think.
Do you know what is the year now?
Yes, it's 2025.
Okay, and do you know where are we now?
Yes, I am in hospital.
Okay. Can you please tell me, can can you count from December months backward?
Okay, December, November, October, September, okay, August. I think this is enough. Okay.
Yes, thank you. And do you have any stressful condition in your life, like
Yeah, all
any
life
sexual
is have
stress?
stress. All life have stress. I am 75, so I have a lot of stress in my life. Okay.
Okay. Okay. Can you please tell me? I will tell you address, and I will ask you about it at the end of the questions.
Yes.
Okay, it is 27 London Street, for example.
Okay, 27. Okay. All right. Yeah, I write it. Okay. Go on.
Do you know what's my job?
I don't know because you don't have a white coat, but if you have a white coat, I consider as a doctor. You look like a policeman for me.
Okay.
Okay, because in
And
exam you don't wear a white coat. You know that. You are in the shirt or trouser, so you are not in white coat in exam. Okay.
Okay. Can you please tell me what is the Prime Minister?
Of which country?
Who is the Prime Minister of England? Who is the Prime Minister?
I don't know because I don't live in England.
Oh, the Egypt. Sorry.
Okay, I don't know also. I know Mohammed Mahathir. I think he's still, I don't know he's still the minister or not in Malaysia. Okay. All right.
Can you please tell me what is the address I told you about?
Yeah, you tell me 27 London Street.
Okay. So if you can tell me what do you know about the operation we are going to do?
Yeah, I have a hip replacement done 15 years ago by Mr. Wolfson. I think he died now, and now I come to redo it again.
Okay. So I will tell you the risk factor about the operation. The risk factors include like maybe have infection, maybe have anesthesia complications. Okay, and maybe like thrombosis, which is a collection of blood at the site of the surgery. So can you please tell me what is the risk factors that I told you about to ensure that
you tell a lot, and all this is medical. I know that any operation have risk, and you tell me that I can have thrombosis, I can have something like that. So I understand a little. It is like any operation have risk.
Okay. Can you please tell me if you have any medical disease, like diabetes, hypertension?
Yes, I have diabetes, of course. I have hypertension. I take medication for both.
Okay. Are you a smoker?
Yeah, no, it is last maybe 20 years ago. I smoke a lot. I was smoke about 1 pack, 20 cigarettes per day for maybe for 30 years, but I stopped for a long time now, maybe 20 years now.
Okay. Are you alcoholic?
You mean drink alcohol occasionally in weekends?
Okay. So do you have any surgery before?
Yes, I have this surgery before, total hip replacement done before. I have head injury and subdural evacuation. So I have surgery done in my brain.
Okay. And who do you live with in your home?
I live with no one because my husband died. So I just live with my daughter. That's it.
And your daughter could help you after the operation, or
Yes,
standing
of
or
course.
walking.
Yes, of course.
Okay. And um, can you tell me if you have any drugs rather than the diabetes drugs?
Yeah, I have a lot of drug because I've had diabetic hypertension. I take because you don't ask me, but I tell you I have a stroke before, so I take aspirin for the stroke. I take some vitamins and a tonic, so I have a lot of medication.
Okay. Okay, thank you.
Okay, so I think you take about 6 minutes, but actually you don't know what is this station. Okay, I understand, Dr. Ahmed.
Okay, Dr. Sharon. Actually, this patient, I'm not prepared for it until now,
No,
as I don't know
it is
what
not
the sequence.
prepared. It is not a type of preparations, but your attitude that you are have the attitude that you need to take this. I just explain to you what shall we do, and after that we discuss with you.
Okay.
So first, it is important to look to the script. If you look into the script, they have 75 years old woman admit to hospital to do elective total hip replacement, and she had the operation 15 years ago. So it is not at all emergency operation. So in any query, we can postpone. That's it. And your task is you found her confused and need to decide for fitness of the operation. Okay? It is not consent the patient. If you take the consent for sign the operations, you can tell the complications, but you can tell it no problem. So it is like patient is pre or post-operative confusion, difficult to sign or consent, capacity to sign the consent, test for confusion, orientation to time, person, and place. So, Dr. Ahmad, you think that as a surgeon, is many mental state is important?
I think I don't know.
No, it is not important. Okay, from psychiatric point of view, you think
Yeah,
that the psychiatrist use it?
no.
Okay, so what is used? They use now something called 480. Okay, this
Okay.
is 480. It is including AMT4, which is orientation to time, person, and place. Simple way. All over the world use it. Either 480 or orientation to person and places. So forget this. So you ask, good morning, I am Dr. Ahmad, one of the orthopedic team. Can I know your name? How old are you, or date of birth, up to you. What time is it now? Morning, afternoon. You can give her address and ask. You can ask about here. You can ask about the name of place, which is a hospital. If you are wear coat, you can ask what you know that I am. So you are a doctor. You have white coat. This is a nurse. They have the special dress for the nurse. After that, you can ask something like current president. You can count from 10 to 1. You can ask about the address. This is enough. And it is the important. You need to ask about any other system. You don't ask about other system, Dr. Ahmed. So the first mistake, you don't ask about other system. Other systems, including have nausea, vomiting, fever, loss of weight, coughing, chest pain, aware of your heartbeat, and any problem in urination or defecation. Okay? So ask about other system. Any history, you must about other system. Second, past medical history, hypertension, diabetes, dyslipidemia. past surgery, past admission. Of course, I volunteer to tell you I have stroke, I have subdural, all this, but you don't ask. Family history, allergy, you don't ask about allergy. Social, you ask about social. After that, this is what is called abbreviation mental state. So if you go to back, this is the abbreviation mental state. You can use it, which is AMT4, but in rapid way. And this is also including orientation to time, person, and the place. Not for you, for anyone, just ask the same. I repeat it again, the time, the address, current year, current location, and you ask according your country. So for example, in Malaysia, we ask about Merdeka. Merdeka is Liberation Day, or Diba Valley, or Prime Minister of country, not UK, or something like that. So it's just an easy way. What is the important? The important, you need to ask about trauma, especially head trauma, stroke, infection, because some patients have UTI, especially old people become drowsy, hypoglycemia and take a medication, liver disease, hypoxia, hyperthermia, hypovitaminosis, medication, because many medication can cause you to be confused. Okay? So after that, the examiner asks you, I finish here, and after that, the examiner asks you. So back to you again. Just orientation to time, person, and the place. Don't forget to ask about social history, family history, medical history, surgery, other system. Okay? It is not how to take a consent. It is to evaluate the patient confusion or the patient mentality state. After that, the examiner asks you in 3 minutes, what you think? Is this patient, are you happy to operate it in this patient or not? What is your answer?
Yes.
No,
Maybe
suppose
if
the patient is
if
confused. Suppose she don't answer you
confused,
many of the questions. So what, are you happy or not?
this is an elective operation and shall be delayed
Okay, so
until
this non-emergency can be delayed. This is the first question. Second is, what is the next step? What is the investigation you need to do for her?
okay, and the next step that I should treat the patient and reassess again.
No,
And
you start by investigation. What is the investigation you need to do?
investigations, maybe make a full blood count and
Full blood count, looking for leukocytosis, urinary tract infection. What else?
Okay, maybe urea and electrolyte for the renal function, and
Okay.
also a liver function like ALT and ACD. Okay, and maybe urine analysis
Okay,
also.
so I think you can start by all investigation: full blood count, urine analysis, kidney function, liver function, blood sugar, thyroid function test, arterial blood gases, all the investigation. And after you found, what radiology also you need to do? Chest X-ray.
I think CT
Okay, go on.
CT brain.
Chest X-ray first, started by simple CT head and brain, and of course, after all this investigation come, I consult either neurology or medical registrar. Okay?
Okay.
All right. Okay, so back to you, Dr. Ahmed again. Of course, you don't happy to have this patient, but don't expect it something we don't tell you. We don't ask you to do many mental state. We don't ask you to have abbreviation mental state. We don't ask you to have this the new one for what is called for ET. So why you start this and we don't ask you this? And also I found some student in exam, he bring a paper and draw something and ask the patient to complete the drawing and all this. I think it is this is surgical exam. Although I found in some books, on some notes, they insisted to have many mental state and they consider it is a station of many mental state. We have a station for mental state, but we ask you, will you please do many mental state to the patient? But this is not this station. History taken is a history taken. History taken must fulfill all criteria of history, including social history, family history, medical history, surgery, and menstrual history if the patient is young. And is not to mention the complication and ask the patient to remember the complication, because it is not a consent. You need to evaluate her like capacity to sign the consent first. And it is not many mental station. Okay. This is a station if the student do many mental state and lost the time, so he don't ask about other item of the history, so is 100% he will fail. In this station, he have no mark, because you need to ask about other system, allergy, social, family, surgery, admission to hospital before. So maybe about 6 mark in this item. All right. It is important in exam. Don't put your mind. Don't expect it what we don't tell you, or don't expect it what we don't need from you. Okay. So Dr. Ahmed, you have a question again or another one? I don't know.
Yeah, doctor. I think
Yes.
actually I have 2 questions also in this station, so it make
Okay.
an confusion. Doctor told me that I don't have to ask about the AMT or the mini mental state without asking in the STEM to make this test.
Of course.
Right?
Yes.
Okay. Okay. Should I ask about the 480 that show in
No,
the
no,
presentation
also
or not?
because 480 is also, I just explained to you, this is the new, but we don't ask about this also, because majority of the students in surgery don't know that, because we are not psychiatrists. We
Okay,
are
but
in
in the
surgery.
station,
We are in surgery. What is important to know if you need to evaluate the patient? Just orientation to time, person, and the place. That's it. You got the idea?
okay,
We don't
yeah,
expect the patient in your country know what is the Prime Minister in UK and what is the World War II time and all these. Okay. All right.
yes.
I with you. What else you need to ask?
In the presentation about the question I should ask, there is a question from the AMT. Shall I ask about it or not?
What you mean by question from AMT?
There is a questions you show it about count from 20 to 1 and
No. I
question
just remember that if you wish to make some simple test, but it is not mandatory. Is a mandatory is just the patient is just either oriented to time, person, and the place or not. We have
okay,
a
yeah.
station, doctor. We have a station about mental state usually in the clinical with cranial nerve examination. This is a different issue, but not history
Yeah.
taken. History taken is a history taken.
Yeah, and I should ask about the orientation to place and the time and system examination, and also about the differential diagnosis for the confusion. That's it, and also medical history, surgical history, and the other social history.
Yes, this is important from surgical point of view. But if you are in other exam, like suppose it is psychiatric exam, is different issue. We examine you in surgery, not in many mental state.
Okay.
We surprised that some student, I surprised even sometimes I have in a station examine the cranial nerve and I found the student ask about many mental state. We don't ask about that. If you am the examiner, if you are in exam, you think the examiner interrupt you and stop you or not? No, he leave you to waste the time because you have 6 minutes. So you lost your time for asking this unnecessary question. And at the end, he say he don't ask about other system, 2 mark. He don't ask about allergy, 1 mark. He don't ask about family history, 1 mark. He don't ask about any hypertension, diabetes, dyslipidemia, another 1 mark. He don't ask about smoking and alcohol, so another mark. So he found about 6 mark is lost from you. So this is easy because it is very common, especially in Middle East. The student fail simply because they answer a question we don't ask about it. Okay, if you are query, you still query in exam, you can ask the examiner directly after you finish everything. You need for me to do many mental state. He said, you know, If you are still not trust or query, just ask him. He said, no need. We don't ask you about this. We don't be volunteer to answer something we don't ask about. All right. I think that you are maybe against your beliefs in some area in Middle East, but this is exam, and this is why this is a station. If you find the station is repeated for many times in your country, it means that the student answered it wrongly. So they still have it. If the student answered it correctly, we don't repeat it. Yeah. Any question, by the way?
Thank you, Doctor. The Doctor, you mentioned about my attitude toward this station is wrong. Can you please explain this?
Yeah, we start from the beginning. You start your station by say hello. Okay? So we don't say hello. Hello, you can tell it to your friend. But for the exam or for the patient, you say good morning or good afternoon. This is first. Second, you come straight forward. For example, you ask about, you mention complication, and this is not a matter to mention complication. So this is unprofessional. And also, I think it's okay, but you don't ask about other system, and also it is fatal. Because you are put in your mind that it is a station of many mental state. I think so. This is why you put your question or your effort in this. So this is why. And you ask about prime minister. So it is also unlogic, except if some famous, like for example, Mahathir in Malaysia, Gamal Abdel Nasser in Egypt, something like that. But if you ask the lay people now about the prime minister in some countries, they don't know it. So it is also unlogic question if you depend on it. Okay. It is important, don't enter the station, put your mind this station for this. Dr. Abdurrahman Rahuma, I think he elevated his hand. What you need to ask, Dr. Abdurrahman? I hear you.
Good afternoon.
Good afternoon.
My question about ordering operation list, patient COPD and metallic heart valve. I ask about type of anesthesia.
All right, I bring you the station because I understand what you mean. Okay, I know what you mean because it is mistake from the record. Okay, I just open it for you. Just for the others to know, because I understand what you mean.
Okay.
You have, okay, just a minute again. You have this station. You see the screen?
Yes.
You have Mr. or Miss Ashley, 62 years old woman, complain of chronic obstructive pulmonary disease, have a pacemaker, admitted for repair of strangulated hernia. The question is not in front of you in the exam. It is in front of examiner.
Okay.
Okay, so I will ask you. So what type of anesthesia you prefer in this patient? What is your answer?
My answer, regional tab block.
Yeah, regional, you mean local anesthesia or spinal anesthesia?
No,
Yes.
not spine. Regional. Tab block.
Say again, what is regional mean?
Tab block.
What is
rectus abdominis block.
You mean local anesthesia?
Local anesthesia. Yes, local anesthesia.
No, it is impossible to doctor to do local anesthesia in strangulated hernia.
With the sedation.
Because even we don't, it is impossible because you make a traction on the omentum.
Okay.
Okay, but back to your answer, you mean that you need to know to tell me that in chronic obstructive pulmonary disease, I prefer regional anesthesia.
Yes.
Which is include
spinal.
No, suppose it is a spinal. So the examiner tell you I agree with you, but the anesthetist is not happy with that. So why the anesthetist refused to do that? The
Spinal
anesthetist
hematoma.
refused to be spinal because of spinal hematoma.
Yes.
So after that, the examiner asks you how to follow up. So because why this patient have spinal hematoma?
Because patient on anticoagulant.
So why you know that it is anticoagulant? We don't mention that. What you know that is an anticoagulant?
Patient have a pacemaker.
Yeah, because the patient have artificial valve or pacemaker, so most probably have oral anticoagulant. So how to follow up this oral anticoagulant?
By warfarin.
No, how to
By-
follow up
by-
warfarin?
Yes, by INR.
What is INR?
International normalizing ratio between
It is ratio between what and what? Prothrombin and control. What is normal prothrombin time?
15 seconds.
15 seconds. Any other prophylaxis you need to give to the patient with strangulated hernia?
Antibiotic.
Antibiotic prophylaxis. And usually if you open the content or open the hernia or open the intestines, you need to give cephalosporin and metronidazole. Okay. What type of diathermy used in this patient?
Bipolar.
So where you put the patient blade?
No plate.
No patient blade. Okay. All right. So this is the first case you choose. The third case is this one. 70 years woman complaining of the left diverticular abscess, admitted for Hartmann procedure. She is allergic to penicillin and iodine. Is any bowel preparation needed?
No.
Why?
Because the patient urgent surgery for colostomy.
Urgent patient. It is urgent for Hartmann procedures. What is site of colostomy?
At the left side of the abdomen.
Why left?
Because left
Because
side.
diverticulum is usually left side, very rare to be in the right side. Okay?
Yes.
And this mention here, I think is mentioned left. Okay, no problem. Is this patient, which antibiotic you give, although the patient is sensitive to penicillin?
Third and fourth generation cephalosporin.
All right. So this is tricky question because we don't ask you what is the substitute of penicillin, which is vancomycin and erythromycin, because normally in colon surgery you give penicillin.
Please
In
again,
colonic
doctor?
in colon
Yes.
surgery, we give
Yes.
penicillin. No.
No, we give
So
third and fourth
we
generation.
usually give the third cephalosporin and the metronidazole.
Yes.
So because what I found in exam, most of the students, yes, the patient is sensitive to penicillin, I give him vancomycin or erythromycin. It is correct if I ask you, I have a patient with skin abscess and the patient sensitive to penicillin, so what I give to him? So the answer is you give him vancomycin or erythromycin. But here in colonic surgery, you don't give penicillin. Which material used for skin preparation?
Chlorhexidine.
Chlorhexidine, and it is pink in color. Back to the third one, which is the last case. Although it is insulin-dependent diabetes mellitus, and you make the patient at the end of the list because they have MRSA. What is MRSA?
Methicillin resistant
Staph aureus.
Staph aureus.
What is methicillin?
Antibiotic.
It is historical antibiotic. We don't use it now. How to prepare this patient as a diabetic patient, insulin-dependent diabetes patient? You give him an infusion pump, you give him glucose insulin through the infusion pump, and the insulin you give it is Actarabid, which is short-acting soluble penicillin. And you measure the blood sugar every hour. Of course, you give an infusion pump because it is not logic to give the patient subcutaneous every hour because we measure the blood sugar every hour.
Okay.
And what is the precaution for AF? How to treat it?
Beta blocker and for rate, to control the rate, and the rhythm amiodarone, and
Okay. Dr. Abduraouf, in your hospital or in your
yes.
country, they allow you to treat a cardiac patient.
No.
What is it? what is the answer? So the answer is this question. If this in surgery, not in physiology station, I consult the cardiologist, and he usually treats the underlying cause like electrical disturbance. I can help them in that, but he usually controls the rate, and the rest controls the rate by beta blocker and the rest by amiodarone. But if the patient have low blood pressure, it is better to avoid beta blocker and to give him digoxin or calcium channel blocker. The last question, which is most of the students answer it wrongly. What type of flap used in ischemic patient?
Equal flap.
Equal flap.
Fish mouth
yes.
flap.
Okay, so equal flap, we don't use long posterior flap because in the most of the book, even the Google, I show you in the Google, they also, in the Google site, he write it wrongly. What we called it, long posterior flap, which is wrong. I just bring it just to have an idea. So I share again. Okay, you can see the screen. I asked Google because we found the student asked this wrongly. Type of flap below knee in ischemic limb, and he answered long posterior flap. It is wrong answer. We have skew flap, or what we called it equal flap. Anterior and posterior are equal, because if you make the posterior flap long, it is become ischemic. So it's not proper flap. Although in the most of the book, although in the Google, they have this mistake, but it is wrong. All right, this chlorhexidine. So this is okay, Dr. Who's asked? Dr. Abdurraouf. So why you ask, what you are worried about? Why you ask this question in particular? Because of the regional anesthesia or for what?
Regional anesthesia, بس أنا
Because regional is a term. You mean not spinal and you need to give local.
Yes.
No, it is impossible to give locals in the strangulated hernia. If normal hernia, like hernia, straightforward hernia, you can give local.
This answer of this question spinal.
No, the answer is not spinal. The answer is general anesthesia.
General anesthesia, okay.
Because spinal can cause hematoma. Although I tell you what is the mistake coming from here. All over the world, they think that, which is true, if the patient have chronic obstructive pulmonary disease, it's better to give him regional anesthesia, which is spinal or local. So they give spinal anesthesia. But if the surgical patient, which patient is an oral anticoagulant, like patient with coronary bypass, patient with valve, patient with intracardiac device, is not wise to do that. Okay. So you can say, although it is chronic obstructive pulmonary disease, but I give him general anesthesia. I am afraid from spinal hematoma. This patient is not suitable for local anesthesia because this strangulated hernia maybe need to have resection anastomosis. This question is variable from exam to exam and from day to day. So some days you can find the patient have no strangulated hernia. So your answer is correct. Some days the patient have no cardiac problem or no metallic valve or no pacemaker. So it is different from day to day exam. So it is not a fixed question. This is variable question. Okay, you agree?
Okay.
Any questions? Okay. So I think for people in Malaysia, we start again in Monday, because I think next Monday, most of the students next Monday will be 13. Maybe some already started the exam. So we start in the same time, 3 o'clock, 8 p.m. in Malaysia. Okay. Any other question? Over here. Okay. So next